Thank you, Professor Yu, for your kind introduction. Many thanks for the organizing committee to inviting this terrific joint symposium. My task today is to deal with the trends of NASH-HCC risk in Taiwan. Compared to the global prevalence of 25%, Taiwan is have a higher prevalence of NAFO. According to a previous community-based study, by recruiting more than 2,000 patients, more than near 1 decade, as you can see, the left side that the prevalence of the general population is 45%, range from the 26% of those aged less than 30 to 54% of those aged 50 to 70. There is a parallel increase association between the BMI and the prevalence of NAFO. Of note that for those normal BMI, there is still 26% of the prevalence of NAFO. And among those obese and lean NAFO patients, we found that insulin resistance was the significant predictor for NAFO. Modified by lifestyle and the genetic predisposition, the simple steatosis can progress to liver-related event and hepatocellular carcinoma. So the grave outcome of this hepatic manifestation of metabolic syndrome is the liver cancer, which is the fifth most common cancer globally and the second most frequent cause of cancer-related deaths. I draw your attention that 10% of the HCC are of unknown underlying etiology, such as alcohol, HPV, HCV, and other environmental toxin exposure. A large part of them, mainly are due to the fatty liver-associated HCC, range from 6% to 26% in a different region. We have a chance recently to look at our hospital regarding the past 1 decade, the newly diagnosed HCC registry database. As you can see that there is an increasing parallel of the non-B, non-C HCC in the past decades. There are many predictors of NASH disease progression and HCC risk, such as lifestyle, obesity, insulin resistance, genetic predisposition, and age. From simple steatosis to NAFO to NASH is quite dynamic and is reversible. And the HCC can occur in the presence or absence of the fibrosis and cirrhosis. So from it's quite more frequent from NASH to progress to NASH plus fibrosis, and reversal is less common than the disease progression. So overall, the annual incidence of HCC is quite quite variable, range from 2 to 13% in different stage of this disease. As you all know, that previous studies have demonstrated very clearly that chronic hepatitis C-associated cirrhosis had a higher risk for HCC development as compared with the NAFO and cirrhosis. However, the impact of the public health still remained substantial due to the extraordinarily high prevalence and huge burden of obesity and the metabolic abnormalities. So the final result of the hepatocellular carcinoma was quite equal. So this study was a large-scale community-based cancer screening program study conducted by National Taiwan University Hospital. This study recruited a large number of participants from the community and follow up for more than 10 years. The study aims to investigate whether there is an association between the between the HCC, diabetes, obesity, and other metabolic factors stratified by Hep B, Hep C, the disease status. The major finding for this community-based study is that there is a significant association between the HCC and the obesity and diabetes. Of note that for those patients without Hep B or Hep C, there is an increased significance association between the metabolic factor and the development of the HCC. For those patients who carried more than 3 metabolic factors, namely the hypertriglycemia, hypercholesterolemia, obesity, diabetes, and hypertension, they have the relative risk of 3.8 compared to the those who carried 2 factors more and less. When the analysis restricted to those older than 50 years at enrollment, the relative risk increased to 4.2. So from another aspect, Professor Huang from the National Health Research Institute conducted a multi-center cohort based on the Taiwan Liver Cancer Network, recruiting more than 3,800 HCC patients. 11% of them were non-B, non-C HCC. After the multivariable analysis, there is a significant association between the non-B, non-C HCC and the metabolic factor, such as fatty liver on echo and on ultrasonography, hypertriglycemia, and diabetes. There is also an incremental of the HCC risk according to the number of risk factors. The left panel shows the non-cirrhosis, the right figure shows the cirrhosis. So it demonstrates nicely that the metabolic risk may contribute to the development of the non-B, non-C HCC in Taiwan. What's the clinical characteristic among these non-B, non-C HCC? We have fortunately have the chance to collaborate with the Stanford University to conduct this retrospective cohort study by involving more than 3,800 HCC patients in US and in Taiwan for 1 decade. The major finding is that 1/3 of non-B, non-C HCC patients were non-cirrhotic, which was significant more than Hep B and Hep C groups. Secondly, non-B, non-C HCC patients presented with large tumors at more advanced stage disease than viral HCC. And those who have the non-B, non-C HCC has a worse overall survival as compared to viral HCC. The left figure demonstrates that the overall survival for those non-B non-C HCC patients is the lowest as compared to with the viral HCC. And the right panel shows the non-cirrhotic patient were put into analysis. Also demonstrate that non-B non-C HCC have the worst survival. We further examined our single center, the cancer register database, trying to look at, to validate the result. And we recruit more than 1,700 newly diagnosed HCC patients. 19% of them are non-B non-C HCC, and 38% of them are Hep B, 38% of Hep C, and then B and C HCC were 5%. And we found that the non-B non-C HCC patient exhibited a higher prevalence of diabetes as compared with the Hep B and Hep C groups. For those, also we also found that the non-B non-C HCC patient have the worst survival as compared with the viral HCC patients. Even those stratified, those patients with those cirrhosis patients, we can observe that non-B non-C HCC patients have the lower survival as compared with Hep C and Hep B. According to recent review article conducted by Mayo Clinic Professor Louis Roberts, Japan and Taiwan, these two countries, have the excellent survival of HCC as compared to other regions globally. This is because the contribution of the many gastroenterologists and pathologists' efforts, and also these two countries have a very excellent surveillance program for the patients. And so more than 70% of the newly diagnosed HCC patients in the medical centers in these two countries were at a very early stage of HCC, and therefore are eligible for the curative therapy. So it's raised the concern that how the importance of the HCC surveillance in non-B non-C HCC patient in Taiwan. We further look at the stratified or data or patient into two groups. The one is the curative therapy, who received the curative therapy. The other is palliative therapy. For those who received curative therapy, there is no significance of the overall survival in 4 groups. However, for those who received the palliative therapy, the non-B non-C HCC patients also have the worst survival as compared to the viral etiology. So it raised a concern that the HCC surveillance should be more important in non-B non-C HCC patients. So in our clinical practices, we should have the patients into the 2 directions. The mission for us is to identify those with NASH, because having NASH may significantly increase the risk of disease progression, particularly the fibrosis progression. The second part is to identify those at risk for progression to cirrhosis, because the fibrosis and cirrhosis is the first gap, first bridge to hepatocellular carcinoma. So we have to pay more attention to those patients with significant fibrosis because it's associated with increased mortality. How about the to the lifestyle modification could regress the fibrosis in NASH patient. This study recruited more than 200 paired biopsy patients. NASH resolution, NASH reduction, and fibrosis regression were observed in 25, 47, and 19% respectively after 1 year of lifestyle modification. NASH reduction, NASH resolution, fibrosis regression were observed in all 90% and 45% respectively in all patients who have achieved a body weight reduction for more than 10%. The depth panel for this patient showing that for those patients who have the baseline fibrosis, when they achieved more than 10% of body weight loss, 81% of them can have the disease regression. For those patients who have no baseline fibrosis, if they remain, they can remain to the fibrosis progression-free if they maintain the at least 5% of body weight loss. Another very large-scale study from the European country that to address whether the physical activity can reduce the HCC risk. For this very large study, that there is an increase of the significantly increased association between the total physical activity volume and the risk of and decrease the risk of HCC. As you can see, both in the left figure and the right figure, either total physical activity or vigorous physical activity, the higher volume of the physical activity, the lower chance and the lower cumulative instance of HCC can observe. So in the consideration of this disease natural cause from the simple steatosis, NASH to NASH-HCC, previous study demonstrated that it's estimated that each step takes about 7 to 8 years to achieve. Although each step may have the chance, very few chance to develop HCC, but the phenomenon also exists from the fatty liver to NASH and the NASH cirrhosis. So in the battlefield of the non-C HCC scenario, we should protect our patients in the battlefield. So we must know that what's the enemy, what are the enemy, and what are the direction the enemy come from. And that some enemy are modifiable, some enemy are non-modifiable. And through this, we also to look back our patients, which is more susceptible and which is not which is more resistant to the insult of the fatty liver disease. So we can figure the risk stratification, precision lifestyle modification for patient, and precision therapeutic, although there's no approved medication for it. And also we should assess the cardiovascular risk and also the HCC surveillance put into our clinical practice daily. So in summary, my talk, dear Chairperson, ladies and gentlemen, the increasing trend of non-B, non-C HCC deserves more attention in the era of preventable strategy and for HBV and curative intent for Hep C infection. Metabolic derangement contribute to the development of non-B, non-C HCC even in an early fibrosis stage. The worst outcome and poor survival of non-B, non-C HCC may raise the importance of HCC surveillance strategy and the early curative approach. Thank you for your attention.